Welcome to our free webinar. My name is Jennifer Bonner. I'm a certified nurse midwife with over 15 years of nursing experience, and I am so excited that you are joining me today for this free webinar on miracles in motion. We're going to talk about maternity nursing, all the things that go with it. I'm so excited. This is my jam. I love this information so much, and I'm hoping that we're going to be able to break it down together. So before we get going, just a few housekeeping things. We are streaming on all platforms. So if you are joining me in the Zoom and you have a question, please go ahead and put that in the Q&A. I'll try to get through as many of those as I possibly can. If you are joining me on Facebook or YouTube, go ahead. You can put those questions in the chat there as well, and I will try to keep an eye on those as we go. So if you are joining us on TikTok or Instagram, make sure you like, you share, and let your friends know that are struggling maybe with maternity nursing that we're here. We're going to break down these important concepts. So if you've ever joined us for one of our free webinars, you know that we are going to use something called Slido. And the very first question I have for you is, where are you joining us from? Now you're probably saying, okay, Jennifer, I see the Slido on the screen, but how do I use it? Well, that's a really great question. So what you're going to want to do is go ahead and grab your smart device, go ahead and scan that QR code there on the screen, and that will get you into our poll for today. This is just a really great way of connecting with other students, talking, kind of participating with others all over the world. So go ahead and jump in there. If you can't use your smart device, you can go ahead and just go to slido.com. You're going to enter in the code maternity with Archer, and that will get you in as well. So we have people all over joining us: Dallas, Nigeria, Calgary, Florida, Australia, California, Houston, Guam, Ontario, New York. I'm in Ohio. So excited to have you joining. Let's go ahead and see where our Instagram is at. Seeing lots of people joining. Don't forget to share. Right, people from all over the world: Philippines, Arizona, Canada, Massachusetts. Awesome. So excited to have you joining us. I know, regardless of where you are, this is one of those areas that can be a little bit difficult. And so what we're going to do is we're going to check out what our client has going on today. So Mrs. Jones is a 31-year-old female. She calls her OB and says, "I think I'm pregnant. I've had a positive pregnancy test. I'm really tired and I'm lacking some energy." So if we think about it, we know that there are three different signs of pregnancy. So I want you to tell me, which one do we think our client is most likely have? What sign of pregnancy is that positive pregnancy test? Is it presumptive? Is it probable? Is it positive? What do you think? What sign of pregnancy is that positive pregnancy test? Right, I'm seeing a lot of probable. I'm seeing presumptive. So remember, we have presumptive, we have probable, we have positive, and many of you are saying probable. I'm liking it. So let's talk through what those different signs of pregnancy are. So presumptive are these symptoms that could really be explained lots of other ways. So maybe it's, well, let's think about the number one sign here that we see at the top of the screen. And this is just a really great way to remember those signs and symptoms of presumptive pregnancy is when we use the word presume. So period absent, really tired, enlarged breasts, sore breasts, urination frequency, movement perceived in emesis and nausea. So we see there at the top, period is absent. What are some things that could cause a period to be absent? What do we think? What are some reasons? I think diet, PCOS, stress, hormone issues. Maybe they're really active. You got it. Yeah. So lots of things could cause a period to be absent. What could cause emesis and nausea? What other things could cause emesis and nausea? What do you think? I think stomach ache, GI issues. Maybe they had food poisoning. Yes, there's lots of things that can cause that. So when we're thinking about presumptive signs of pregnancy, there are a lot of different things that can cause this to occur. So we want to keep an eye on those. Now, we're going to become more sure of what's going on with our probable signs of pregnancy. Now, when it comes to probable, chances are you are probably pregnant if you have a positive pregnancy test. So if you answered probable in my last vital question, you're absolutely right. So there may be other things that explain it, but there's not a whole lot of them. So positive pregnancy test, occasionally there are certain types of cancers that can turn a pregnancy test positive, but most likely, if you have a positive pregnancy test, you are probably pregnant. Ballottement. Ballottement is when we push on the baby. Sometimes it is through the uterus, sometimes it's through the cervix. But basically, what happens is that baby's kind of like a balloon. When you tap a balloon, it kind of floats up and comes back down. This is what ballottement is with the baby. So it will kind of back off from where it was pushed and then come back down. Um, Feeling the outline of a baby, softening of the cervix. We call this Goodell sign. This tends to start at about 4 weeks. And just that softening as the cervix is getting ready to do a really big job. We also have Chadwick sign. That's this bluish discoloration, typically to the vagina, the cervix, even the vulvar area you can see. And then we have something called Hagar sign. Hagar sign is where we have that lower uterine segment that starts to soften up, and that's in between 6 to 8 weeks. Now, those are our probable signs of pregnancy, and we're going to move to the most positive signs. There's nothing else that's going to explain pregnancy like positive signs of pregnancy. So there's no other explanation when a healthcare provider sees that fetal movement. When the healthcare provider is able to hear those fetal heart tones using a monitor, a Doppler, or the ultrasound that shows a baby, seeing that baby move. Um, through by that healthcare provider. Now, what is it that all of these things have in common? When we look at these signs of pregnancy, there's something that they all have in common. What is it? What is it that all of these have in common? The healthcare provider. Yes, the healthcare provider is seeing these things. They are involved. You got it. Nice work. Now, someone had asked, what's the main one for our probable signs of pregnancy? All of these are good ones. You could be asked on any of these, so I would definitely want you to know. So we go in and we ask Mrs. Jones, when was her last menstrual period? And she says it was 10, 25, 22. So when we are looking at talking about the menstrual period, What is it that we are going to use in order to calculate her estimated due date? There's one particular thing that we're looking at in order to help calculate that estimated due date. What is it? Let me know in the chat, or if you are on Facebook or YouTube, you can use those platforms as well. Okay. Yep, we're going to use that LNP, but we're going to use Naegele's rule. You got it. For those of you that said Naegele's rule, you're absolutely correct. So when we use Naegele's rule, this is actually one of my favorite things to do. One of my favorite things to do. Let's go ahead and grab this again. There we go. Um, just a moment. Something just. There we go. Okay. So Naegele's rule. Now, this is a great way to figure out the estimated due date. Now, you're probably saying, Jennifer, I have my smart device. I have a wheel. I have lots of ways to figure out what the estimated due date is. Why would I need Naegele's rule? Well, sometimes those things go down. Sometimes we don't have our wheel, and so we need to be able to figure this out. So we're going to take the first day of the last menstrual period. We're going to add 7 days. We're going to subtract 3 months, and we're going to change the year, and that's going to give us our estimated due date. Okay, that's going to give us our estimated due date. Now, something that's really important is when we are doing this, we need to know how many days are in each month. So in this case, our last menstrual period was 10, 25, 22. Now, how are we going to figure that out? Well, what did I say? We're going to do what? We're going to add 7 days. So how many days are in October? How many days are in October? Go ahead over here. Can get out my trusty dusty. So we have 31 days in October. So I'm going to add 7 days. So 25, 26, 27, 28, 29, 30, 31, 1. That's going to get us to 11, 1, 22. And then I need to go backwards 3 months. So from November, I go back to October to September to August. Okay, so August, and then I'm going to change the year. Okay, so it might look something like this. Let me get rid of my little drawing there. Okay, so we add the 7 days, that gets us to 11/1. We subtract 3 months, that gets us to August 1, and then we're going to change the year to 2023. Okay, I know that can be a little bit confusing sometimes, but I hope walking through that would be helpful for you. So let's head back to Slido. I have another question for you. I want to know, what if the LMP would have been January of 2022? Would that change the year for her due date? What do you think? Is that going to change the year for her due date? Her LMP would have been in January of 2022. Would that change the year of her due date? No, it wouldn't, because it would be in the same year. She would be giving birth the same year of her last menstrual period. Okay. So that's something to think about, just some considerations as we move forward. So let's break down these trimesters just a little bit, kind of talk through what are the highlights that we are going to see as we go through. So the first trimester, this is where that fertilized egg is going to change from a small grouping of cells to a fetus that's starting to have a baby's feature. So in that first month, we have this all or nothing effect. If the embryo is exposed to those harmful teratogens, then at this point, because the organs haven't formed yet, it's either going to cause the pregnancy to be lost, or if the pregnancy is not lost, then nothing's going to happen. Okay. In our second month, we have those facial features continuing to develop. Neurotubes are developed. And at 6 weeks, we can detect that heartbeat through ultrasound. Then in month 3, we have that circulatory, the urinary systems. Those are functional, pretty remarkable. I love seeing how all of this ends up coming together. So we need to calculate Mrs. Jones' GTPAL. So remember, this is a great way to be able to understand what her obstetrical history is, to be able to communicate with other providers. So we need to go ahead and calculate this. She tells us that along with this current pregnancy, she has a history of a healthy delivery at 38 weeks, an emergency C-section at 29 weeks where the child did not survive. So what would be her GTPAL? What do you think here? You can let me know in the chat. Getting some great answers already. Be her GTPAL. Would be her numbers. That's what we're looking for here. Okay, so we know that gravida is what? The number of times she's been pregnant. So we can see right here, she has a current pregnancy, so that's a G1. She has a history of a healthy delivery at 38 weeks, that's G2, an emergency C-section at 29 weeks where the baby didn't survive. So she is a G3. The next thing we need to figure out is her term pregnancy. So how many of these were term? 38 weeks. So she's a T1. Okay. The next thing we're going to look at is her preterm. So these are anything 20 weeks to 36 weeks and 6 days. And so we have one of those. That was the emergency C-section. So P1. Abortions in this case is any delivery that occurred before 20 weeks. Okay. And she doesn't have any of those. So she's an A0. And for L, we want to know how many children are currently living. And it's that 38 weeker. So in this case, she is going to be a G3 P T1 P1 A0 L1. Okay, any questions on that before we move forward? We're going to break these down just a little bit more. We're going to talk about gravidity. So remember, this is the total number of pregnancies that she has had. Our twins are going to count as one with our G's. And remember, sometimes they'll try to trick you on the exam. She's currently pregnant, and that also counts. The T is for term. So this is term pregnancies. And we know that term starts at 37 weeks, not 36 weeks and 6 days, 37 weeks. So if she's 37 weeks or beyond, that counts in our T column. And remember, twins count as one here. And then we move to preterm. Preterm is anything from 20 weeks to 36 weeks and 6 days. Our twins count once here. It doesn't matter if the baby survived or not. That counts in the preterm if they were delivered between that time. And then we have abortions. Now, when it comes to abortions, there's a lot of different things that come to mind here. Typically, we think about miscarriages, but in this case, an abortion is any delivery before 20 weeks. So from conception up to 19 weeks and 6 days, our twins count as one here. But when it comes to living children, this is where our twins count as two, or if it's triplets, it counts as three. And this is a fluid number. It can change from year to year. So let's go ahead back to Slido and check out our next question here. So Mrs. Jones, let's go ahead and grab this one. She states she's concerned about her nutritional needs. What nutritional needs would we want to educate her on in this situation? What nutritional needs would we be concerned about in this situation? What are we going to educate her about? AMC folic acid, prenatal vitamins, avoiding food with mercury. Okay. What types of food she should and shouldn't consume. So oily fish is okay. It's a good source of omega-3s. We want to be careful with those ones that have a lot of mercury. We want to be careful with the caffeine, avoiding raw foods. You got it. Nice work. All of those things are concerns here. So we also want to make sure that she's getting enough calories. So typically we want them aiming for about 300 additional calories per day. But if they started pregnancy overweight, we're going to decrease that, maybe just 200. If they were underweight, we might increase it a little bit to maybe 400, but making sure they're getting those proteins, those complex carbs, fibers, healthy fats, all of those things are going to be really helpful in the development of the fetus, right? Other things we might consider, folic acid. We definitely want her to be taking that prior to pregnancy to help with neurotube defects. We want to prevent those as much as we can. Other things, calcium. So calcium, we're going to find that in dairy products, broccoli, kale. This is going to help with bone and teeth development. Vitamin D. Vitamin D, you're going to find that in fatty fish like salmon, maybe even fortified milk or orange juice. Those are helpful for, again, bones and teeth of that baby. Iron, we find that in meat and beans. We want to make sure if they're taking this as a supplement that they take it with a good source of vitamin C. It's going to help with that absorption. So typically what I'd recommend is my client go ahead and take that with a chewable vitamin C. DHA, iodine. Iodine, salt is now iodinized, so rarely do we see this as an issue, but we mostly find this in our animal protein. So beef liver, chicken, fish. Also in seaweed is another good place. Now, what about the things to avoid? We definitely want them to avoid those things, meats that have not been cooked. So we want them to avoid sushi, red meats, making sure that those are cooked thoroughly to get rid of any chance of bacteria that might be there. Raw meats, raw eggs, cold deli meats. They can have the deli meat. We want to just make sure if they, let's say they head on over to Subway, we want to make sure that they are getting those toasted so that any bacteria that might be present is gone. Caffeine, they can have a little bit. We typically say about 1 cup a day. And alcohol, we encourage them not to partake in those. So 2 weeks later, Mrs. Joan calls and she says she can't keep anything down, including her fluids. Now, with that type of concern, what are we thinking is going on here? What would we be concerned about? What would we be concerned about in this situation? Said she can't keep anything down. No fluids, no foods. What are we concerned about? Hyperemesis, gravidarum. I like it. Nice work. You're right. Yeah, we're concerned about hyperemesis gravidarum. Now, a lot of times when I was working through this information, it was really difficult for me to distinguish this from morning sickness. And they're very similar, except hyperemesis gravidarum is much more complex. It's more severe to the point where they can't keep anything down. We're seeing weight loss, electrolyte imbalances. It's not going away, it's persisting. So morning sickness is just a touch. Typically it goes away. They're able to keep some things down, but we're not seeing the weight loss. We're not seeing the added issues of electrolyte imbalances and things like that. So when do we get concerned? Well, if we're seeing those things, if they're dehydrated, so their mucous membranes are dry, they have tenting, they don't have that good skin turgor, maybe they're tachycardic because their body's trying to compensate, they're losing weight. Now, a lot of times we will see some weight loss in early pregnancy just because of um, the food aversions and a little bit of nausea, but typically it's going to pick up after a while. But if we're starting to see those things listed here, the electrolyte imbalances, we get concerned and we need to talk about what it is that they can do. So typically we're going to start with just some basic things. getting some crackers in your belly before you stand up, getting something on your stomach, sitting up after meals, eating small, frequent meals throughout the day instead of three large meals, drinking liquids in between your meals, and then going back to just kind of a bland diet, nothing too spicy, nothing too hot or too cold. And a lot of times that is going to settle things down. Now, if that doesn't cut it, we're going to move into our medications like promethazine. That's going to be our go-to. There is something on the market called diclegis, which is essentially vitamin B6 and Unison put together, makes a great combination to help with these clients. Now, if those things are not helpful, they may need some IV fluids to help with that electrolyte imbalance. And in rare and serious cases, they may need something like TPN as well. So let's check on one more thing with our client. So 28 weeks, she comes in, her vomiting's finally under control, and provider tells her it's time to do a glucose tolerance test. Now there's two types of these that we're going to look at. The first one is a 1 hour. In this one, there's no need for our client to be fasting. We go in, she's going to be given 50 grams of glucose. And then we're going to check her blood sugar an hour later. If that blood sugar is greater than 140, she gets to do a 3-hour glucose. Now, most of the time I see a question that says, okay, can she go do that right away? No. And here's why. The 3-hour glucose test is going to give us our diagnosis, but it's something that she needs to be fasting for at least 8 hours prior. Okay. There is no need for fasting with the 1 hour glucose tolerance test, but there is a need to be fasting for the 3 hour. Now with this one, she's going to be given another drink, but this is going to have 100 grams of glucose in it. So what's going to happen is we're going to check a fasting blood sugar. We're going to give her that 100 grams of glucose, and then we're going to check her blood sugar 1 hour after, 2 hours after, and 3 hours after. Now, if her fasting at that point is greater than 95, she's diagnosed with gestational diabetes. If her 1 hour is greater than 180, her 2 hour is greater than 155, her 3 hour is greater than 40, those are abnormals. And so if we have two of those three that are abnormal, then that also will give a diagnosis of gestational diabetes. Okay. So we go back, we check on our client, and what do we find next? Her blood glucose with that 1 hour test is 163. Does she have gestational diabetes? What do we think? Does she have gestational diabetes? Many of you are saying yes. Many of you are saying she's got to do that 3 hour. That 1 hour is really elevated. So chances are we're going to go ahead and diagnose her, but we could go ahead and send her for that 3 hour for lots of different reasons. Maybe she didn't understand the instructions, but chances are we are going to go ahead and diagnose her with gestational diabetes. Now, gestational diabetes is where we have diabetes during pregnancy. Um, and so the pancreas basically is unable to keep up with the demands of the body. And we have several risk factors. Many of them are related. So somebody that has a sedentary lifestyle, they're obese, they've had gestational diabetes before, they have a family history, maybe they have a history of pre-diabetes. All of those things are going to increase their risk. And so we are going to want to make sure that we do these tests to ensure that they don't have gestational diabetes, because that can lead to a really big baby. And that can lead to earlier than we would prefer deliveries, because big babies can get stuck. We can have what's called a shoulder dystocia. They can cause some trauma. It can increase the risk of preeclampsia and also hypoglycemia for that baby, because this whole time, mom has been supplying a large amount of glucose and the baby has been responding by creating insulin, right? Well, what happens when the baby is delivered and they're no longer receiving all of that glucose, their body is still used to it, so it's making a lot of insulin, and that leads to a drop in their glucose. So find out Mrs. Jones, she gets her blood glucose managed, we give her some insulin, and she's finally feeling better at this point, and she's going to come back to see us in 2 weeks. So if you are struggling, maybe you're getting ready to sit for boards or you're not sure where to start, let me encourage you, check out our SurePass combo. It's our #1 recommended package. It comes with all of our on-demand videos, our full Q bank, and our 3-day live review, which will be occurring actually this week, starting tomorrow through Friday. Our 3-day live review is a jam-packed time of high yield information that you're not going to want to miss to be successful on your board exam. And here at Nurture Review, we are incredibly thankful for you being a part of our family here. And we want you to know that regardless of where you are on your nursing journey, we have a place for you. Whether you just got accepted into nursing school, you're thinking about nursing school, or maybe you've already passed boards and you're headed on to become an advanced practice nurse, we have a spot for you. And we are absolutely thankful to have you along this journey. We love celebrating your successes. We love coming alongside you in those valleys. And we thank you so much for trusting us in those seasons of life. So thank you so much for joining us. I hope to see you back next week for our next free webinar. And make sure that if you join us for our 3-day live this week, you pop in and say hello. Thanks so much for joining us. We'll see you next time.